I think there was some confusion about the case presentation because I was under the impression that the case will be presented by one of the students, rheumatic heart disease, something that we don't normally discuss much in these fora. So I think this is just an introductory slide which says that rheumatic fever results from infection with specific strains of group A streptococcus or gas as we call it. It involves many systems besides heart, for example, brain, skin, joints. But why we talk about it? Because its major effect is due to damage to the heart valves. And unfortunately, we continue to see a large number. Perhaps it has declined in some parts of India. The numbers have declined. However, in many other parts of India, especially when we talk of Bihar, UP, Rajasthan, we still see a lot of cases of rheumatic heart disease and rheumatic fever in children. But I know in southern states of India, the numbers have gone down, except in few pockets in some of the states. So how does it happen? What is the pathogenesis? Simply the answer is that the exact pathogenesis is not known. However, as we discussed, that infection with group A streptococcus, which is basically the agent, produces sore throat. Often it is sore throat. Rarely it can be skin lesions. And in addition to the agent, there is involvement of the environment, because it is generally believed that the rheumatic fever, rheumatic heart disease tends to happen in those countries where there is overcrowding, unhygienic sanitary conditions, less access to healthcare, and on top of that, there has to be a susceptible host. So if 100 people develop group A streptococcal sore throat, only 3 in endemic regions will develop actually rheumatic fever, and some of them will recover. Only half of them or less than half of them may go on to develop rheumatic heart disease. So it's just a sort of a interaction between host, environment, and agent. And that produces the first episode of ARF in some cases, acute rheumatic fever. Now, those who develop acute rheumatic fever are very likely to get further episodes of rheumatic fever. So this is a susceptible host we are talking about. And every episode of rheumatic fever will produce some damage which may be permanent on the heart valves, and that is what results in rheumatic heart disease. As I said, we don't know exact pathogenesis. However, there is an interplay between the 3 basic epidemiologic agents, that is host, environment, and agent. So these are the phases of rheumatic fever. Now we must remember that everybody may not pass through all the phases. There are patients who present for the first time with rheumatic heart disease, and if you ask them, they have never had a history of joint pains in the past. Similarly, those who present with rheumatic fever may not even remember that they had sore throat in the preceding 2 or 3 weeks, because sore throat is such a common phenomena. But in patients who are presenting during the acute phase, you may be able to get a history of sore throat in the recent past, because usually joint pains will appear within 2 or 3 weeks of sore throat, so it is easy to remember. But after joint pains also, there may be a long latent period before they actually develop damage to the heart, or so-called rheumatic heart disease. So these are conventionally 3 stages or phases of rheumatic fever, but then, as I said, everybody may not pass through all the 3 phases, and therefore it becomes really difficult to control rheumatic heart disease, because we may miss these 2 phases in many of these patients. Just to give you the global burden, very large number of cases still exist, because as we know, the regions which have a lot of rheumatic fever, rheumatic heart disease are the most populous region of the world, be it Africa or India or Pakistan or even to some extent China. We have a large number of patients who are, because of rheumatic heart disease, are in congestive heart failure. In fact, rheumatic heart disease is the commonest cause of congestive heart failure in under 40 years of age. So if you have a relatively younger patient who is in heart failure, the very high likelihood of this patient having rheumatic heart disease. Number of deaths huge, as you can see, and a large number of patients require valve surgery. Unfortunately, all these patients are not able to get valve surgery done simply because there is no capacity to take care of all these patients. But at least requirement wise, there is a huge number waiting for the valve surgery. Because of high incidence of rheumatic fever in some of the areas or regions of the world, we keep adding new and new cases of rheumatic heart disease to this pool of 38 to 41 million cases. Why we talk about it is because rheumatic heart disease theoretically at least, is the only truly preventable chronic cardiac condition. So we can talk about hypertensive heart disease, coronary heart disease, valvular heart disease. Whatever we do for them is really not preventing the heart disease. It is likely to develop in those who have the risk factors. But rheumatic fever and rheumatic heart disease is the one which can actually be prevented completely. And that is why it is important to know about rheumatic fever. Because once it develops, it becomes very debilitating for the children and young adults. So this is the data from the publication of 2017. I must say this is more based on modeling because there may not be enough data from all the countries. But the important thing to highlight is that these are patients who are diagnosed by clinicians. That means they have murmurs. These are not subclinical rheumatic heart disease. The number of subclinical may be 5 or 6 times or even 10 times more than what is shown here. So India obviously has the largest burden of rheumatic heart disease cases. 13.17 million is the estimate. Next comes China. And of course, the other countries have a much lower population, therefore their numbers are also small. But if you take these 5 countries, then a large number of rheumatic heart disease cases worldwide are based or are living in these countries. And of course, on top of that, we have African continent, which again has lots of rheumatic heart disease patients. Not only the cases, what is important also is that the mortality that we have with rheumatic heart disease is very high in India. And almost 40% of all mortality of RHD happens in India simply because our cases are presenting much later. So you will see more rheumatic heart disease in some of the other areas of the world, but they are presenting at a much milder form of the disease or much earlier, and therefore the mortality is much less. So India not only has a huge burden, but it also has a very large mortality contribution of RHD to the worldwide mortality. So how do we assess a patient? Because very often you will get a patient of rheumatic heart disease in your exam. So how do you go about assessing these patients? We of course start with a history. We ask history of suggestive rheumatic fever, that means joint pain, swelling, restriction of motion, etc. In the past. And you would probably get it in about 50% of cases. Somehow patients of mitral stenosis are less likely to give history of rheumatic fever than patients of regurgitation, mitral or aortic. We also like to know when was the last episode, how much time has elapsed, because generally speaking, we talk about 2 or 3 years at least from the episode of rheumatic fever to rheumatic heart disease. But then we have something called malignant form of rheumatic heart disease where this latency may actually be quite less. Patients often will have symptoms related to rheumatic heart disease, the commonest being dyspnea, but there could also be palpitation from volume overloading. Patients of severe mitral stenosis may present with paroxysmal nocturnal dyspnea and orthopnea. PND is quite a classical feature of severe mitral stenosis. There could be even hemoptysis. Then how the patient has behaved over the last couple of years since the onset of symptoms. And then we do ask very specific symptoms which may point to a particular kind of heart valve lesion, for example, hemoptysis, PND suggestive of mitral stenosis, palpitation suggestive of volume overload, or it could be palpitation due to arrhythmia. The commonest arrhythmia that we come across in RHD patients is atrial fibrillation, which is basically seen in those who have long-standing valvular heart disease. If a young patient complains of chest pain or even syncope, then one has to think about aortic stenosis, because we know that these symptoms could be related to aortic stenosis. And sometimes patients or their relatives do complain of neck pulsations, which could be because of dilated dilated ascending aorta due to AR, or it could sometimes be severe venous pulsations because of tricuspid regurgitation that may happen secondary to pulmonary arterial hypertension. So these are specific symptoms you should ask, even if they are not being offered by the patient, to find out what kind of valve lesion are we dealing with from the history itself. Many patients will present with congestive heart failure of a short duration. So we need to know what could be the precipitating factors for deterioration in their conditions. It could be arrhythmia, it could be reactivation of rheumatic carditis, not uncommon in the pediatric age group at least. Then, of course, besides their clinical assessment, where we look at their severity of the valvular lesion, rheumatic heart disease is very easy to pick clinically because there will be murmurs, murmur of mitral regurgitation, murmur of MS, murmur of aortic regurgitation, and of course, TR. So these are the common murmurs that we are likely to hear in patients who are presenting in young age, for example, under 15 or 20 years of age. And if we find these murmurs, then it's likely to be rheumatic. Common cause is likely to be rheumatic heart disease. We must always look for any evidence of active rheumatic carditis, especially when we are dealing with pediatric age group under 12 or 13. And that would be in the form of inappropriate tachycardia, recent onset of congestive heart failure. You do have to look for rheumatic nodules. I think we all know major and minor criteria. I'll show you a slide on that also. But these are something that we often miss. We don't look for nodules because we know that nodules have to be seen on specific parts of the body, which patients will not complain of simply because they are painless nodules. Then, of course, we always get an X-ray, ECG, echocardiography. The idea is to know what is the severity of the lesion. Clinically, it's a fair method to detect severity. Most of the time, we are able to detect severity, but of course, now with the availability of echocardiography, it is very easy to know how severe the lesion is, especially in those cases where you have multivalvular involvement. Then we need to know whether to start some therapy on these patients or not. We need to assess if the patient was advised secondary prophylaxis to prevent further episodes of rheumatic fever, and whether this is the time to go for any intervention, whether it is transcatheter intervention or surgical intervention. So a comprehensive assessment of a case of rheumatic fever, rheumatic heart disease would include valves affected. Mostly, as I said, it will be mitral and sometimes mitral and aortic. Isolated aortic involvement is relatively uncommon. What is the severity of those valve lesions? What is the NYHA class of the patient? Whether the patient is in heart failure or not? Is he or she in sinus rhythm or there's atrial fibrillation? What is the degree of pulmonary venous hypertension, which we often diagnose by the symptoms of the patient? If patient is class 3 or 4, then we know it has to be severe pulmonary venous hypertension. We also have to write about pulmonary arterial hypertension, and that we usually go by the severity of P2 or the loudness of P2 and left parasternal lift or impulse. We also try to assess if the LV function is normal or not, and that could be from the third heart sound presence, which is important in AR, but we must remember that in MR, you may have a third heart sound without LV dysfunction. Of course, the kind of apex, whether it is diffuse, will also indirectly tell you whether there is LV dysfunction or not. Then, as I said, in pediatric age group, we must rule out acute carditis and therefore look for nodules, etc. And we have to make a diagnosis. When we are writing a diagnosis, we have to say that there is no acute carditis or there is acute carditis. The second thing we should rule out is infective endocarditis, although it is rare in pediatric age group, but in older patients, it is not that uncommon. And ultimately, we also should write what is produced the patient to worsen recently if he or she has worsened and come to the hospital. So what is the precipitating factor? And believe me, in our country, anemia is also an important precipitating factor, and therefore we need to specifically look for anemia. Now I'll just show you a couple of examples. This is a 6-year-old young girl who is presented with very short history of just 2 weeks, recent onset of class 4 dyspnea. I mean, looking at just this history, you will also think about myocarditis because it's a short history. It's not going to be congenital heart disease. But she also gives history of fever and joint pain 6 weeks back. And this immediately puts the diagnosis as rheumatic fever leading on to rheumatic heart disease. Examination wise, she is in heart failure and she has a pensystolic murmur at the apex. Very simple case. Patient is presenting with features of mitral regurgitation, likely to be RHD. Since the history is short, we should also think about acute rheumatic fever or carditis presenting with heart failure. Now, what should we do next for this girl? We need to investigate like any other case, but please don't jump to echocardiography because we know she has severe MR. Echo is not going to tell us anything more than that. We know she's in heart failure, so her MR has to be severe. What we should do is to rule out carditis by sending the specific investigations like ESR, anti-streptolysin titer. These are the ways to diagnose carditis clinically, CRP levels, etc. Of course, go for echocardiography. Echocardiography may also show you some features which are suggestive of carditis, and of course, manage the patient. So, how do we diagnose acute rheumatic fever? So the trouble is that there is no specific diagnostic test or a tool for saying that this patient has acute rheumatic fever. So we all have to go by the various signs and symptoms, and of course take help of lab tests to make that diagnosis. And therefore the clinical acumen of a person or the clinician is very, very important when we are dealing with a patient of rheumatic heart disease or rheumatic fever, because if you are experienced in dealing with these patients, then your diagnosis of carditis is likely to be correct. Of course, we have to confirm it by the lab parameters. So these are, the sort of constellation of symptoms and signs, as you can see, and we know them as Jones criteria, who started off giving these criteria in 1944 when rheumatic fever, rheumatic heart disease was still common in US. And you will see that there are some major criteria and some minor criteria that was given by Dr. Jones. Obviously, they are all clinical criteria, except some laboratory criteria which are corroborative of the diagnosis. Again, nothing is diagnostic here, even in the lab parameters. So what you get by anti-streptolysin titer, etc., only tells you that there has been a recent streptococcal infection. It doesn't tell you that this infection has led on to rheumatic fever. So there were lots of modifications, and these modifications happened because the rheumatic fever, rheumatic heart disease tended to just disappear from the Western world, and they started to see things like juvenile rheumatoid arthritis or other causes of joint pains. And therefore, over the years, these criteria have been modified number of times. What we have now are the latest ones in 2015, and I think all of you are very well aware of these criteria, and they're often asked in your exam, in your theory, as well as during the case presentation. So for the first time, the criteria were set different for different population. I think that was a very sensible thing to do, because regions like ours, where we have moderate to high risk of rheumatic fever, rheumatic heart disease, we need to be a little more liberal in diagnosing rheumatic fever, rheumatic heart disease, unlike in Western world where the risk of population is very low. So they came up with two sets of criteria, and generally we see that arthritis and carditis are more frequent, are the most frequent major manifestation. Arthritis is often seen in older children. Carditis is more common in younger children, the pediatric age group that we deal with. Chorea, we know, is much less common, but is also a delayed manifestation. You are not going to see a patient who has arthritis as well as chorea. That's very unusual. Other major manifestations are quite rare. So this is the 2015 modification. There are two things that they have done. One is, of course, they divided the population to low and moderate high risk, but they've also defined criteria for recurrent ARF, something that was not mentioned in the original Jones criteria. So here for initial ARF, you have to have two major or one major plus two minor, but for recurrence, you could have even one major, even three minor criteria to call it recurrence of rheumatic fever. So what is different here? Subclinical carditis. This has been added for the first time, and that would mean echocardiography, because you obviously diagnose subclinical carditis by echocardiography. So for the first time, Jones criteria have included echocardiography here, and therefore the criteria of subclinical carditis has come. Besides that, in moderate and high risk population, they also made polyarthralgia as a major criteria, which was actually a minor criteria earlier and still remains minor criteria for low risk population. So polyarthralgia, and not arthritis necessarily, and monoarthritis has also been added on as a major criteria. Of course, chorea, erythema marginatum, subcutaneous nodules remain the same. In the lab, in the minor criteria, monoarthralgia has been added, which was never there, and evidence of preceding gas infection, which could be in the form of ASLO titer or any other anti-streptococcal titer, which tell us that there is preceding group A streptococcal infection. Even the criteria for ESR and CRP are different in high risk or moderate risk population. So what are these criteria for preceding gas infection? Positive throat culture, if you can get. Usually we don't go for it. We are usually in the lab doing anti-streptolysin O titer, but so there are some labs which are also doing anti-DNase B titer. And of course, a combination of several titers can be seen as anti-streptozyme titer. You may not get one value which is high, and in fact, the cutoffs are also variable from lab to lab. Generally, we say 250 units for adults and 333 units for children is taken as a cutoff, but those are based on really old studies where normal children were looked at and their levels were defined, and that is how those figures were reached. So I would say that if you are doubtful, but clinically you strongly feel that patient is active, then rising titer will be a good idea. That means you take one sample today and take another sample after maybe 4 or 5 days or even 7 days. And if you find that the titer, which was let's say 200, has become 300 or 333, that will be more important to make a diagnosis of rheumatic fever. But again, it really varies from lab to lab. So how do we diagnose rheumatic carditis? As I said, very easy. By auscultation, you're going to get murmurs of regurgitation. That means murmur of mitral regurgitation, murmur of aortic regurgitation. You may also get mid-diastolic murmur sometimes because of inflamed mitral valve. We call it Carey-Coombs murmur. It is generally said that rheumatic carditis is a pancarditis, so you are likely to get features of myocarditis. A lot of data has shown that there is actually no myocarditis element to it. And there is proof that if you operate on very sick patients who are in failure, they do well. And if myocarditis was there, they would not have done so well. So myocarditis is more like a myth, I would say. Yes, pericarditis can happen, and we occasionally come across patients who present with pericardial rub or even small amount of pericardial effusion. But again, having a large effusion is very unlikely in acute rheumatic carditis. And also we must remember that don't make a diagnosis of rheumatic carditis when you're not hearing any murmur, because valvulitis is the primary thing that happens. So if somebody presents in failure but has no significant murmur, it is not going to be rheumatic heart disease. Now the question is then, what is subclinical carditis and how to diagnose? Again, I think we all are aware of the criteria to diagnose rheumatic carditis. And this is a case where you can see that the mitral valve has nodules. Nodules are seen over here also. You may also get small amount of pericardial effusion and of course mitral regurgitation. Commonest lesion, almost 80 to 90% of patients of rheumatic carditis will have mitral regurgitation. Small amount of effusions are not uncommon. Sometimes you might even miss them. You have to really make an effort to see if there is effusion or not. So this is typical clinical carditis that you see on echo. For subclinical carditis, there are criteria again defined in 2015 publication also by WHO also, where they say that you need to differentiate pathological from physiological mitral regurgitation. I think this is again a question that is often asked in the exam, and you should really be aware of how to differentiate pathological MR from physiological MR, and how to differentiate pathological AR from physiological AR. And these are, the criteria that have been shown over here that have been published earlier. Now, what is the natural history of rheumatic carditis? The milder the carditis, better is the prognosis. And this is a study that is compiling some of the data which has been published in the past. And it shows that if there is no carditis in the initial episode, the likelihood of rheumatic heart disease is nil. But if there is severe carditis in the first episode, then the likelihood of rheumatic heart disease is almost 100%. That means almost everybody is going to get rheumatic heart disease if the patient had severe carditis. And when I say severe carditis, I mean severe mitral regurgitation, patient may be even in heart failure. So severity of initial carditis and recurrences of ARF are very important prognostic markers for development of chronic rheumatic heart disease. So what are the challenges in diagnosis? As I said, the established guidelines, the criteria, they're all very, very good, but they cannot substitute the physician's experience and common sense. There are several other conditions that can fulfill the Jones criteria, which are not rheumatic carditis. And diagnosis of recurrences can also be difficult. But in our country, especially in pediatric age group, one must suspect a recurrence, even if all the criteria are not meeting, by worsening of previous valvular lesions. If you knew that patient had mild MR and now has severe MR, by presence of a pericardial rub, even I would say unexplained recent onset heart failure in a child who was doing reasonably well, one must think about acute carditis or acute rheumatic fever. And of course, if you have a high SO titer, that will also indicate that there has been a preceding gas infection in the recent past. So since we do come across that kind of a challenge often, we have published our data of 126 children over here, as you can see. And again, what we found was that the Jones criteria were often not satisfied by patients being treated for acute rheumatic carditis. And again, recent unexplained worsening of dyspnea, young age, significant mitral regurgitation, nodules on the mitral valve on echocardiography, and elevated CRP were important indicators that we may be dealing with acute rheumatic carditis. And remember, these are usually what we're talking about is in children. You're usually under 12 years of age. So based on our experience, we came up with this scoring system to diagnose acute rheumatic fever in children with carditis. And we gave scores to the age, to the NYHA class, to the severity of mitral regurgitation, presence or absence of mitral nodules, ESR less than 50 or more than 50, and an ASO titer of 250 or more. The total score possibly could have been 13, but what we found was that if we get a score of 5 or more, we are likely to be dealing with patient of acute rheumatic carditis. And the sensitivity of this scoring system was 76% with specificity of 79%. And that was quite good. And therefore, by diagnosing rheumatic carditis by this scoring method could mean that we will be able to diagnose more cases rather than miss cases. Now, how do we manage? Of course, take care of the group A streptococcal infection. Penicillin happens to be the best drug even today. There has been no resistance shown to penicillin of this streptococcus bacteria. Symptomatic treatment of clinical manifestation. If there is heart failure, you give them diuretics. If there is severe MR, give vasodilators, but must not rule out valve surgery. We don't want to do valve surgery during carditis, but sometimes patients are so sick that one ends up advising valve surgery for these patients. Again, regarding bed rest, limitation of activity, we need to individualize. But generally, I would tell my patients, who, especially those who are in failure, not to exert much. Maybe not bed bound, but house bound. Do not go out to play. Secondary prophylaxis with penicillin is always to be recommended for all these patients. And these are some of the treatment or the drugs that we use. As you can see, in severe carditis, we are using steroids, a significant amount, and we usually would go on for 3 to 4 weeks with full therapy and then taper over the next 6 to 8 weeks, thereby covering about 12 weeks of therapy with steroids, which is generally the duration of the one episode of rheumatic fever. In case patients of mild carditis, we can just do with aspirin. We need not add prednisolone. For moderate carditis, it is quite questionable whether to go for steroids or aspirin. It's really something that there is a lot of debate on it. I don't want to go into the details of those. Polyarthritis responds beautifully to aspirin. In fact, you can use aspirin as almost a diagnostic test. If somebody comes with severe polyarthritis and one dose of aspirin does wonder to that patient, it is likely to be rheumatic carditis. Chorea, late manifestation, but you have to use these drugs. Even with these drugs, chorea can go on for 3 months or even 6 months in some children and can be very debilitating in some of these patients. So what about surgery? I would say that surgery should not be done as far as possible. However, if there is intractable heart failure and you have something like a flail mitral leaflet, like you have over here, the chorda has been broken. So this is like a flail leaflet. No amount of medical management is going to help these patients. And therefore, these are rare patients where you may have to go for surgery even during the acute phase. I know it's difficult to convince your surgeons, but I guess you have to push for surgery in such patients. And most of these patients will end up with valve replacement because repairing valve during acute phase can be quite a task for most of the surgeons. So I'll just show you another example of a 12-year-old boy who came with dyspnea class 3, rather long history of paroxysmal nocturnal dyspnea for last 2 years, denies any history of rheumatic fever in the past. Examination typically reveals a long mid-diastolic murmur suggestive of mitral stenosis with severe pulmonary arterial hypertension and secondary or functional tricuspid regurgitation and is in heart failure. Lab parameters, because it's a child, we should always do it, and they were negative for acute rheumatic fever. This is the X-ray. You can see some amount of cardiomegaly, some amount of PVH over here, and this is the ECG showing you left atrial enlargement. This is V1. You can see over here also, and the axis is almost normal, and there is right ventricular hypertrophy. So there is left atrial enlargement, right ventricular hypertrophy, very classical ECG for severe mitral stenosis. There's an occasional ectopic also over here. So mitral stenosis, we know, produces pulmonary venous hypertension. it enlarges the left atrium, produces pulmonary venous hypertension. Now we are dealing with chronic rheumatic heart disease and not acute rheumatic carditis. We also know that mitral stenosis predisposes to left atrial thrombus, which can go on to develop embolism into the brain or elsewhere. And this leads to pulmonary venous hypertension because of LA hypertension, leads to pulmonary edema sometimes, which can give you hemoptysis. Then there is pulmonary arterial hypertension, which dilates the right heart, that is right ventricle and right atrium, producing tricuspid regurgitation. There is congestion in the liver, which is enlarged. There could be even ascites. There is edema and severe tricuspid regurgitation secondary to pulmonary arterial hypertension. What is important to remember is that in mitral stenosis, there is a very classical relationship between the functional class and severity. If somebody is coming to class 3 or class 4, you should not hesitate in calling this patient as severe mitral stenosis because there is a direct relationship. So how do we assess the severity in a patient of chronic mitral stenosis? Long diastolic murmur, longer the murmur, more likely to more severe mitral stenosis. Narrow A2OS interval. So long murmur, presystolic accentuation, narrow A2OS interval, severe pulmonary arterial hypertension. There may be cardiomegaly because of right atrium and right ventricle enlargement and left atrial enlargement. Left ventricle is not enlarged. And of course, there could be congestive heart failure. So this is the classical echo. You can see that there is doming of the mitral valve. There is thickening of the mitral valve. There is turbulence because of mitral stenosis. There is severe tricuspid regurgitation, although the tricuspid valve looks opening well. And this is giving a gradient of about 70, suggesting that there is severe pulmonary artery hypertension and tricuspid regurgitation. Once you have a patient of MS, even if you don't have a history of rheumatic fever, you know that 99% of cases of MS are because of RSD, especially if you're getting it in a child who's more than 5 or 6 years of age. In younger children, it could be congenital, but in older children, it's likely to be rheumatic heart disease. It's much more commoner in girls than in boys. There could be variant latent period. If you look at the Western literature, they talk of 10 years, 15 years latent period between rheumatic fever and rheumatic and severe mitral stenosis. But we don't see that. We see much younger children with severe MS. Patient predominantly presents with dyspnea, breathlessness because of pulmonary venous hypertension. And of course, if it is severe MS, any stimulus that produces tachycardia, whether it is walking or fever, one can actually get into paroxysmal nocturnal dyspnea and orthopnea plus hemoptysis. What we also have to see in echo always is to look for an LA clot because mitral stenosis is notorious for producing thrombus in the left atrial cavity, although it is less common in pediatric age group and in those who are in sinus rhythm. Predictors of thrombus would be atrial fibrillation, a large left atrium. In those who have normal sinus rhythm also predisposes to LA thrombus. And when we are doing an echo, look for spontaneous echo contralto sec because that will also indicate that this patient may be about to develop thrombus in the left atrium. Thrombus in the left atrial cavity will be seen very easily, but when it is in the appendage, you have to make special effort to look at the LA appendage. Sometimes you even have to do transesophageal echo to look at the appendage, which may not be very easily visible on transthoracic echocardiography. So when I said the latency from the onset of rheumatic fever to the development of mitral stenosis, it is much shorter in countries like India. There is data from Ethiopia and other African countries where within a span of 2 to 3 years, patients have developed severe mitral stenosis. And when we see such patients, then we must remember there is something called juvenile mitral stenosis, a term that was coined in India by Dr. Roy and Dr. Bhatia. And this was published quite some time ago, I think in 1963. So what do we mean by juvenile mitral stenosis? Juvenile mitral stenosis means severe mitral stenosis developing below 20 years of age. There is rapid progression. These patients are quite symptomatic in class 3 or class 4. They have thickened mitral valve with severe subvalvular deformity, but they do not have calcification. Severe pulmonary arterial hypertension, sinus rhythm in almost. Just give me a second. I think there's some battery issue. So severe pulmonary arterial hypertension, and almost all of them are in sinus rhythm. So atrial fibrillation is quite unusual when we talk of young patients with mitral stenosis. And because they do not have atrial fibrillation, therefore thromboembolism is also very rare. Although we say classically juvenile mitral stenosis below 20 years, but some children who are less than 12 years of age are also coming with severe mitral stenosis, and they may actually be worse off because of the malignant nature of the disease in developing countries like India and several other countries. So how do we manage the second case that we discussed who is in severe MS? I think it's a very simple answer. You have to go for balloon mitral valvotomy. So that is how we have to treat them. Fortunately, that's a good uh, modality for most of these patients, although it is not curative. Many of these patients will come back with restenosis, but the rates are rather low, and therefore patients may go on for 10 years or even 15 years without another intervention. Now, this last case is a 15-year-old boy who's presented with gradually increasing breathlessness again for the last 3 years or so, had joint pains about 5 years ago. So there is history of rheumatic fever in the past, claims to be on regular penicillin prophylaxis. Examination shows severe chronic mitral regurgitation, and again lab parameters as routine are negative. You can see a precordial bulge. The ECG shows left atrial abnormality, left atrial enlargement, as well as left ventricular hypertrophy with volume overload, suggestive of mitral regurgitation. And this is the X-ray showing cardiomegaly, straightening of left heart border, very classical for rheumatic heart disease again, because of left atrial appendage enlargement. And of course, you can see the left bronchus is lifted up, producing left atrial enlargement, suggesting left atrial enlargement. And this bulge that you are seeing on the right cardiac border is actually the double density. So it's all left atrium. So in chronic MR, if you see them, what you have to ask them is the history. You will find much more palpitation, although dyspnea may be there, but it usually is a late feature. It is the palpitation. In fact, many of the patients with severe MR may remain asymptomatic for long period of time, for maybe 5 or 6 years or even 10 years before they develop symptoms. They may have slightly high volume pulse, unlike AR where you have severe collapsing pulse. Hyperdynamic precordium may give you precordial bulge in children. Left ventricular apex, which is down and out on examination. There may be systolic thrill. S2 tends to be wide and variable, and S1 is soft. P2 may be loud if there is some amount of pulmonary arterial hypertension. You may have, besides the pansystolic murmur of apex radiated to axilla, that is MR, you may have flow murmur at the apex, which may be in the form of LVS3 if it is not very severe MR, or an MDM, mid diastolic murmur at the apex because of severe MR. But remember, there will not be any presystolic accentuation, and S1 will be soft. So you can rule out mitral stenosis. Heart failure occurs much later. As I said, patients may be asymptomatic for a long period of time. Heart failure is a later feature in chronic MR. Heart failure may be there in acute MR, like in rheumatic carditis, but in chronic MR, heart failure occurs later and would usually indicate presence of left ventricular dysfunction. So this is the echo. You can see that there is eccentric jet. That's usual. Wall hugging jet, as you can see. So this is severe mitral regurgitation. LV is dilated but seems to be contracting reasonably well. But what you see over here is ejection fraction of 57%. So LV is 66, 65.9 and 45. So ejection fraction calculation wise is coming quite okay. But remember, in patients of mitral regurgitation, your ejection fraction should be actually supernormal. So if you have an ejection fraction of 57%, it's actually low and would indicate severe mitral regurgitation with some amount of left ventricular dysfunction, because we expect ejection fraction to be more than 60%. In aortic regurgitation, again, you may have long asymptomatic period. Almost always you have associated mitral regurgitation or even mitral stenosis. Isolated aortic stenosis is quite rare. In fact, in pediatric age group, we hardly see aortic stenosis. We generally see aortic regurgitation, maybe some minor mild aortic stenosis. Commissural fusion, like you have in bicuspid aortic valve, is the hallmark. Again, the severity is assessed by cardiomegaly, length of the early diastolic murmur, which may become hollow diastolic. And of course, classically, we see all the peripheral features of AR. Hill sign is very important because Hill sign can tell you the severity of AR by the difference in systolic pressure between upper limb and lower limb. Now, whether it is MR or AR, we know that vasodilators are helpful. But if you look at the literature, you will realize that there is hardly any data on long-term benefit of vasodilator therapy. We often put these people on ACE inhibitors, but the data is really not very robust. You may use vasodilators in AR to reduce the systolic pressure in these patients, but I think those who have severe mitral regurgitation or severe aortic regurgitation with dilated ventricles, with or without ventricular dysfunction, may be the right candidate for starting vasodilators. So we should avoid vasodilators in moderate severity of regurgitant lesions. Again, those who have stenotic lesion associated with regurgitant lesions, one should not use vasodilators. One vasodilator that we found to be very useful in acute cases of mitral regurgitation is nitroprusside infusion. It's quite helpful. It can stabilize the patient to some extent till you can think about surgery. However, one has to give it very carefully because it can produce hypotension, and therefore invasive blood pressure monitoring is what is recommended when we are using nitroprusside. We know that penicillin has to be given as secondary prophylaxis. Diuretics only if patient is in heart failure. Beta blockers have no proven benefit. In fact, in aortic regurgitation, they may lower the diastolic pressure, produce bradycardia, and actually could worsen these patients. The patient may develop angina. Anticoagulants to be given if there is atrial fibrillation. Secondary prophylaxis, as I said, every RST patient should get it. This is the regime recommended by World Health Organization, as well as we've also published as recommendation in another publication here in India. And the duration is given over here. Although for moderate or severe RST, WHO says lifelong, but we are usually following the Australian guidelines, which say up to 40 years of age, because chances of acute rheumatic fever beyond 30 or 35 years of age is extremely low. Again, there is no data on azithromycin, cephalexin, some of these antibiotics which we just use left and right. We must remember that penicillin is the best drug. It is still very beneficial in the sense that the streptococcus is still sensitive to penicillin. So why go for drugs which are much advanced antibiotics? Because that will really mean that we are unnecessarily using advanced antibiotics and promoting antimicrobial resistance, something we should avoid. For rheumatic fever, for MR and AR, chronic MR and AR, these are the indications for children. Although we don't have the cutoff of LV volume, LV dimension like you have for adults, generally we would go by Z score. However, if there is a decrease in ejection fraction to less than 60% for MR, one must think about surgery, even in a patient who's asymptomatic. In fact, if the ejection fraction is less than 30%, it may be actually a contraindication to surgery because we know that these patients are not going to do well. Ejection fraction always decreases after mitral valve has been repaired or replaced because it was artificially exaggerated. Actually, there is LV dysfunction. For aortic regurgitation, we take the cutoff of 50%, but you can see here that LV internal dimensions can be larger with aortic regurgitation before you send a patient for surgery. But that all is for asymptomatic patients. For symptomatic patients, you have to think about surgery earlier. Perhaps if there is a combined severe MR and severe AR, you may have to think of earlier surgery. Multivalvular involvement is not uncommon. The commonest combination is AR and MS, but you can have AR and MR also. Tricuspid regurgitation is mostly functional because tricuspid valve is normal, but tricuspid annulus is often enlarged because of tricuspid regurgitation. And finally, I will just finish before finishing. I'll just talk about prevention and control because this is again something that is often asked. Primary prevention or primordial prevention. Preventing episode of rheumatic fever by giving antibiotic for sore throat. We don't have a vaccine, so obviously we can't talk of a vaccine, but treating sore throat with penicillin is the best bet to prevent rheumatic fever. Secondary prevention means that one episode of rheumatic fever has happened. How do you prevent the recurrence? By giving them regular benzathine prophylaxis with benzathine penicillin 3-weekly injection. If there is an allergy to benzathine penicillin, one can go for erythromycin. Tertiary prevention means that patient has already developed significant RHD and now you're trying to prevent heart failure and death. And that you do by balloon valvuloplasty, by drug treatment, or by heart valve replacement. But remember, tertiary prevention is actually hardly prevention. This is too late, a stage. So you have to focus your energy on primary, and best is perhaps secondary prevention, which has been found to be most cost effective. And finally, I just wanted you to know that we don't have to really become America or England to to prevent or to decrease our burden of RHD. Many countries which are relatively, I would say, low and middle income countries, which are like our country, have done this job very successfully. And Bangladesh is one of them, and there are a couple of other countries in the French Caribbean island where the RF and RHD cases have been brought down significantly despite their GDP, despite their health budget, and that's because of a comprehensive, focused control program which consists of early diagnosis and treatment of strep pharyngitis, that is primary prevention, aggressive secondary prevention strategy for those who develop even mild rheumatic heart disease, training of health providers, education of the community as well as of the health providers about RF and RHT. A lot of health providers don't even know that there is a link between sore throat and heart disease. They think sore throat is such a minor thing. How can it lead on to heart disease? And of course, whatever cases are there, they require active epidemiological surveillance. So to summarize, rheumatic fever, rheumatic heart disease continues to pose huge global burden in low and middle income countries. The total numbers are still very high. Complete diagnosis is possible in almost all patients by a comprehensive bedside and echocardiographic assessment. Further tests must be done to rule out activity in all pediatric patients. Even if clinically you think the patient is not active, please go ahead and do lab tests to rule out activity. Remember, all modes of treatment are palliative, whether it is uh, surgery or balloon or medical therapy, they're all palliative. Even when you're replacing a valve, you're actually trading one disease with the other disease. And therefore, don't think giving a valve to a patient is a good answer, because we know that there are issues with anticoagulation even after valve replacement. Secondary prophylaxis must continue after intervention also, because if you have done something to the mitral valve, patient can still get aortic valve involvement, and therefore to save another valve, you should continue with secondary prophylaxis. And finally, rheumatic fever and rheumatic heart disease are preventable diseases, as has been shown in high income countries and also has been shown successfully in several low and middle income countries. Thank you for your attention. I'm happy to take questions.